called and the focus of that for me has been on the priority of Parkinson medication, um, the individual nature of its timing across different settings, in long-term care and in hospital, things of that nature. We've delivered a couple of presentations as part of a Get It On Time themed webinar series with the Registered Nurses Association of Ontario, and we're happy for that partnership and happy to have Heather Woodbeck with the RNAO here with us today. We also have Greta Mah. Greta is a pharmacist with North York General Hospital, and she also coordinates their Living Well with Parkinson's program. So she's very well versed in the pharmacology of the medications, but also in Parkinson's disease itself. So again, we're fortunate to have her today, and I'm looking forward to her presentation. With that, I will turn it over to Heather. I'll just mention that if you do have questions, you can enter them in the chat box on the right-hand side of your screen. We'll also be doing a few polls and asking for some feedback during the session on the top right corner of your screen. And beyond that, follow-up questions can be sent to us at the email addresses included here. And again, Heather, if you wouldn't mind sharing the objectives for today's session and some best practices.
Okay, thanks, John. I'm the best practice coordinator for long-term care for the Northwest LHIN, and in that area, or in that position, along with my 14 other colleagues, we try to help long-term care homes implement best practice guidelines. So that's why I'm really happy to be here today talking about best practice as they apply to Parkinson's. And what we want to do together in this presentation is first share best practices for resident-centered care for people with Parkinson's disease. They can be in any setting, but we're particularly interested in long-term care. Provide a bit of an overview of Parkinson's disease and the motor symptoms and how they can be managed. Discuss how the appropriate use of medications can improve Parkinson's symptoms. And then recognize how common non-motor symptoms are related to Parkinson's disease and help to understand their management. So John, if you could put the next slide, please. Now, in long-term care, this relates to residents' rights. We have for those of you not part of long-term care, we have the Long-Term Care Act. And every resident has the right to be protected from abuse. And you might have thought that was a funny one for me to put up. But the compliance branch, which monitors care in long-term care, actually considers not giving medications to be a form of neglect. And so that's one of the types of abuse that they monitor. So I don't think it's happened very often, but there is the force of the law behind giving medications, just in case we need to say something about that. And then the Residents' Bill of Rights, which are built into the Long-Term Care Act, every resident has the right to receive care and assistance towards independence. And using this restorative care philosophy that we have built into long-term care, where we're trying to maximize the independence of residents as much as we can for as long as we can. So as Greta is going to share with you in much more detail than I, but I just want to reiterate that giving the medications really helps a person with Parkinson's to stay more mobile, to have less problems, and just to be better off. And we'll emphasize the importance of giving medication on time. So in the Registered Nurses Association best practices, resident or client, it's called client-centered care, but we like to rename it as resident-centered care. And the core processes of this best practice are identifying concerns and needs of a resident, helping them to make decisions, providing care and services that helps to support the decisions of the resident, and then evaluating outcomes. And you will see how all of these core processes relate to ensuring that residents with Parkinson's get their meds on time and in the appropriate doses. Next slide, please. Now, the next best practice that this is really refers to is the whole prevention of falls and falls injuries in the older adult. this best practice has a recommendation that nurses, along with the rest of the healthcare team, should be doing periodic medication reviews on admission, and then throughout. We do it usually quarterly in long-term care, and at least annually with a pharmacist to look at how their medications. With residents with Parkinson's disease, this is particularly important because they're so sensitive to the doses and the timing of the medications. And we know that residents with Parkinson's, when their medication time is off, they're a lot more likely to fall. And so, Parkinson's medication would be one of them, that the types of medication that puts a resident at higher risk for falls. Next slide, please. Prevention of constipation. Now, this one was one that I've learned a lot about in working with John. I didn't realize this is one of the non-motor symptoms that relates to the Parkinson's drugs. And in the recommendations on the prevention of constipation, the nurses needs to obtain information on any relevant medical and surgical history which may be related to constipation. So Parkinson's is one of those conditions that definitely relates to constipation when the residents aren't getting their medications appropriately. Then it can actually slow down bowel motility and make them a lot more prone to constipation. So, and the next recommendation out of that guideline that's particularly pertinent is reviewing the client's medications to identify those that are associated with an increased risk for them developing constipation. So again, this is one of the best practices that relates directly to this issue of medications. Next slide, please. Finally, I want to point out that we have this wonderful best practice resource toolkit. I've put the link to it at the bottom of the slide there, and you can go on to this resource, and this website has all sorts of resources related to client-centered care, continence and constipation best practices, falls, pain, pressure ulcers, 3Ds, we call that delirium, dementia, and depression, and responsive behaviors. And that's a good place to go for more resources. Next slide, please. I'm going to pass that on over to Greta now.
Hi, thanks, Heather. So for the management of Parkinson's disease is quite complex, so I hope this presentation will empower you and make you feel more comfortable. Even though sometimes when we talk about Parkinson's, we think of someone who's young, like Michael J. Fox, or the recent winner of the Amazing Race. He's only in his late 40s, but majority of the Parkinson's patients are actually over the age of 60. And it's a progressive disease, and it's quite complex as the disease gets more advanced. So patients will have early tremor, muscle stiffness, and then slowly have more shuffling gaits, and by the time they get to the nursing home or they come to the hospital due to falls. So balance is an issue. And on top, as Heather mentioned, not just motor symptoms, there's a lot of non-motor symptoms. The depression, anxiety can happen fairly early. A lot of patients will say, I have constipation all my life, even way before Parkinson's. And then they may also experience other non-motor symptoms. I will explain a little bit more later on. But definitely, as the disease advances, patients are more likely to have some cognitive impairment. So the key symptoms for Parkinson's in terms of motor disability, we can use the acronym TRAP to explain it. T stands for the resting tremor, and then at advanced, it can be even with the function. When they try to hold a cup, they may have some tremor as well. Muscle stiffness, causing lack of facial expressions, and their arms are not swinging as they try to walk, affecting their balance. And a lot of times they complain of like muscle aches and joint pains. So I mentioned, as Heather mentioned about the toolkit, assessing pain is very important for Parkinson patients. Shuffling gait, so it's important to remind patients to walk with the heel first. If they're able to learn this strategy, that would definitely prevent tripping over and fall. Recognize these physical symptoms, allow you to communicate with the physician and periodically adjust the medications. So in terms of the pathophysiology of Parkinson's, The key problem is the degeneration of the brain cells that locate in the midbrain. Is called substantia nigra. So the brain cells in that area are the key producer of dopamine, which is essential for transmission of messages. So by the time we notice initial Parkinson's motor symptoms, more than 60% of these brain cells are already dead, leading to significant deficiency of dopamine. Now, before we talk about treatment, it's important to identify some drugs can actually worsen the Parkinson's symptoms. So if you work in a hospital or long-term care setting, make sure none of the Parkinson patients are on any of these drugs. The two key categories are anti-nausea medication. Patient may be getting some of the older drugs such as Stematol. The generic name is prochlorperazine if they have a bit of nausea, vomiting. So make sure patients are not getting these, or antipsychotic drugs. Patient may have dementia, and quite often doctor may prescribe Haldol if they have behavioral issue agitation. So for safer choices, we can use ondansetron. For antipsychotic drugs, we will use quetiapine. Clozapine is a little tricky to use because it requires blood work, like frequent monitoring. So quetiapine is the top choice in most of the settings. Okay, so now let's talk about treatment for motor symptoms. There are 6 different categories of medications to manage motor symptoms. And in terms of treatment for Parkinson's, the symptoms differ in each patient, so the treatment is geared towards specific individual needs. So levodopa is the most effective medication, and it's the only drug actually becomes dopamine. Unfortunately, well, I think it's a natural process, our bodies have different enzymes that break down or deactivate levodopa. So there are 2 other medications, such as the COMT inhibitor, that by inhibiting this enzyme, it can prolong the benefits of levodopa. And likewise, monoamine oxidase inhibitor can also prolong the benefits of dopamine in the brain. The other category of medication is dopamine agonist, and its main function is to pretend to be dopamine. It doesn't have the same effectiveness like levodopa, but it lasts longer in our body. And I'm sure you noticed the 2 sad faces I put by the amantadine and anticholinergic drugs. We try to avoid using these 2 types of drugs because they cause a lot of disturbing side effects in elderly patients. And occasionally, we still have to use amantadine if patient has very severe involuntary movement. So we try to use the lowest dose as possible. Now, why did I mention anticholinergic drugs are very nasty? They tend to cause memory impairment and affecting patients, not just cognitive function, but cause a lot of hallucination. Dry mouth can affect the appetite, just swallowing. And it's not suitable for patients with enlarged prostate, already having urination problem. And as Heather mentioned, constipation is already a problem for Parkinson patients. So adding this drug will make it worse. So these are the common anticholinergic drugs. And initially, they may be used for tremor, but tremor is not really the worst physical function. It's actually the slowness and muscle stiffness. So tremor is a little annoying for most patients, but most physicians would rather avoid using these groups of medication. Amantadine, as I mentioned, we may need to use a small dose if patient has severe dyskinesia. Same thing, it has the same type of anticholinergic side effect. But if the physician needs to stop the drug, we have to make sure the drug is slowly tapered off, because I've seen patients just couldn't get up the next day as soon as the drug was stopped completely. It's like the body's completely frozen, they couldn't move. So the drug has to be slowly tapered off. The other side effects caused by amantadine include insomnia, swelling, edema, as well as a very unique type of rash, the red skin blotches on the legs. And as I mentioned earlier, our body has different enzymes to get rid of levodopa. So by combining levodopa with MAOB inhibitors, the levodopa can have longer benefits. So the two drugs are sertraline. Sertraline actually will be broken down to amphetamine, so keeping patients awake. So the dose should not be given later than noontime. Sertraline is a newer drug, also in the same category. So both drugs can cause a bit of nausea, dizziness, and as we expected, by keeping dopamine in our system longer, like too much levodopa can cause hallucination, confusion, and dyskinesia. So that's purely due to dopamine activities in our brain if it's too much. We're going to be careful with patients is on sertraline or sertraline. Make sure they're not getting the painkiller called Demerol. The other name for that is meperdin. It can cause a very serious drug interaction. So physician has to be aware and not to use this painkiller, especially after surgery. Fortunately, most hospitals have deleted this medication from the formulary, but it's a good idea to have it on the list. Remind patients never get this if they're on sertraline or sertraline for Parkinson's. So that will bring us to the next group of medications, dopamine agonists. They're available as tablets or the new skin patch. As I mentioned earlier, levodopa is the only drug that becomes dopamine. And dopamine agonist is diamond to help relieve some of the symptoms. In addition to nausea and dizziness, it can also cause some ankle swelling, and is quite potent in terms of causing hallucination, confusion in elderly. So the dose has to be very gradually increased. And some people also complain of very fatigued and drowsy while on this medication. And dopamine agonist also has a very unique side effect. It's called impulsive compulsive behavior. We've met a lawyer who was on this medication, and he couldn't stop gambling, and this is something that he hasn't been telling anyone until the day he realized that he lost so much money and get into debt. So other than gambling, elderly patient in a home setting may be doing repetitive, purposeless movements, such as like keep sorting out stuff in the drawer, taking out stuff, and just preoccupied doing the same motion. For male residents, we have to be careful. Sometimes the drug can cause some hypersexuality. So be careful if they have unusual behavior. This is totally reversible. So the earlier the staff can notice this kind of unusual behavior, the drug should be slowly tapered, and the problem can be reversed. So make sure the drug also needs to be slowly tapered, because if they have withdrawal symptoms, they can be very anxious, having severe dizziness or motor problem. Okay, so here's the drug that I want to focus a lot is the levodopa. Why? Because essentially all Parkinson patients can only be managed by this medication. It's the only drug that becomes dopamine. So sometimes you look at the strings like, oh, how come there's two numbers? The top number represents the amount of levodopa, and the second number represents the combination ingredient, carbidopa, or if the patient is getting the capsule, the second ingredient is benseroside. So why do we need to combine the two medications? As I mentioned, our body has different enzymes, and also when we take levodopa, while the drug is still in our stomach or blood circulation, the drug will become dopamine. So when we have dopamine in our stomach, it can cause a lot of nausea, lightheadedness. So we have to combine this medication with a second ingredient that actually blocks the levodopa become dopamine. By doing that, we get more dopamine get shipped over to the brain, and that's where exactly we want the levodopa to work. So that's why all these medications are combined with the second ingredient. So when is the best time to take levodopa? A lot of physicians specialized in Parkinson's will tell patients, make sure you take your levodopa at least half to 1 hour before you have protein. So never take it at the same time. So if patient's having milk or egg that's high in protein, it can reduce the absorption of levodopa. So it's almost like having a narrow door, only one person can get by. So either the protein can get through or the levodopa. So it's better to space it out. So take the pill first and wait half an hour, then the patient can have their breakfast. And also by doing so, it has additional advantage. That means the patient is getting the benefit of the drug. They can move better or even swallow better, so they can help themselves by feeding themselves with breakfast. And if patients still have nausea problem, patient can take it with some crackers or fruits. And if the nausea is still a problem, some physician may prescribe domperidone, but never give patient Gravol, because Gravol is another drug that causes side effects affecting balance in elderly patients. And if we don't want to use drug, ginger, flat ginger ale also help patients. So drug levels in our body are like peaks and troughs. So soon after a patient receives a dose of levodopa, the drug level goes up and patient's symptoms get relief, and they are more functional when they're on. As I mentioned, they can even try to be a little more independent, and that's really the goal of caring for our patient. As the body constantly deactivates the drug level drops, and patient symptoms return during the off period. So to maintain a constant drug level in the bloodstream, medication must be given on time according to the schedule set by the PD physician. It is based on what has worked well in the home setting. So we're going to watch a little video clip to illustrate the importance of on and off.
In this first clip, we're examining the gait of a 55-year-old man with Parkinson's disease during the off phase. Notice his typical Parkinsonian gait with shuffling and elements of festination. In addition, notice his reduced arm swing. Notice how difficult he finds to turn when asked to do so by the examiner. In the second clip, we're looking at the same patient about 30 minutes later after he's taken his L-DOPA medication. There is a dramatic improvement in his gait, but if you look closely, he also demonstrates some mild dyskinesias of his head and neck as his head wobbles a little bit from side to side.
Okay, so each patient is different in how the body processes the medication and how long it will work in the brain. So therefore, treatment has to be individualized. So your nursing teams usually have tight schedule with established medication times. So if the drug is simply given according to the hospital or the nursing home standard time, instead of the time they are accustomed at home, the patient will not be able to function, or just like the video, like the person saying, is walk properly. So it's not just increase risk of fall and affecting the quality of life, but also make your job more difficult. So patients should be will be too stiff or too slow to do any of the self-care. So the videos show that like even a delay of 30 minutes can significantly affect the patient's movement. So it's important to discuss with the family and find out what's the schedule at home so patient can receive the Parkinson's drugs on time. Okay, so by knowing that, so do you want to give us a guess, like how many or the percentage of patients do not receive the medication at the same time as they were taking it home? So just want to see your estimate, like the percentage. So please just enter that on the screen.
And I will mention that for those on smaller screens, you'll have to scroll down the poll box on the top right to enter your selection.
Okay, I noticed someone put 65 and someone put 50.
So by my count, we have 4 votes so far for 50 and 2 for 65 with some write-ins as well.
Okay, so based on this study, the percentage is 50. But I'm glad to see the response that it is a high number. So that's why the getting on time is very important message to send out to all hospital and long-term care setting. Okay. Okay. So in terms of wearing off, it is related to the progression of the disease. As our brain is producing less of its own dopamine, so the symptom control depends entirely on the levodopa level. So in advanced Parkinson patients, the therapeutic window becomes more narrow. So the adequate control of symptoms become more difficult. And sometimes you may see patients either off, or if they are on, they may have some involuntary body movement. And wearing off refers to the return of Parkinson's motor symptom before the next scheduled dose of levodopa. Okay, and we can detect the wearing off if patients starting to have slower gait or slower hand movement, more tremor, more stiff, more trouble getting out of chair. They may be even feeling more anxious or breathing faster during that time before the next scheduled dose. If that happens a lot and around similar time, they may be experiencing wearing off. So some of the option is to either increase the frequency of levodopa administration, or a patient may be requiring addition of buserelin or a drug called entacapone, or in combination called Stalevo. There's also a controlled release preparation of levodopa. The controlled release medication has been around for a long time. It helps for nighttime dose so that it has longer benefit. The reason why it's more useful for nighttime because the drug itself has a very slow, unpredictable way of releasing the actual ingredient. So sometimes the patient may take the drug and it takes like 2-3 hours before it starts working. So make it unpredictable if it's given during the day. So usually if patient have stiffness at night, then it's better to give it at nighttime. And this pill is not crushable because it has a special coating to maintain that long release function. And as I mentioned earlier about entacapone, this is the drug that inhibits the enzymes breaking down levodopa. So if patient has wearing off, the doctor may prescribe this medication along with levodopa to allow the drugs to work longer in our system. So the drug alone really has no benefit. So if you find you're giving this medication, but you don't see levodopa on your MAR, then it's a question to ask, like, patient has to be taken with levodopa. This drug has to be taken with levodopa. The side effects include nausea, diarrhea, and make sure you tell patients this is not worrisome if they see bright orange urine. And again, if too much medication or dopamine in the system, patient may experience hallucination. And here's another drug that we cannot crush, so no biting or splitting the pill in half. Stalevo is a combination of levodopa, carbidopa, plus the entacapone. So just make it easier for patients instead of taking so many pills. So swallowing difficulty is quite common with advanced Parkinson patients. So we encourage patients to have medication crushed and take with applesauce. And as I mentioned earlier, do not break or crush Stalevo, entacapone, or the CR preparation. Amantadine is available as liquid, so it's a little bit easier. So most of the motor symptoms can be controlled by Parkinson medication, except the unexpected freezing. So I'm going to show a little video to highlight some of the strategy that we can provide the patient.
Let's go, Lou. So, good. That's very good. This is what Lou is doing without having to initiate with the star. This is his normal gait without the star. Once he has cueing for a big step to the star. Okay, and to the mat, big steps. To the green star. To the green star. Yeah, that's very hard. Okay. On the stars, Lou. 1, 2, 1, 2, 1, 2. Okay, turn around. One more step, and then turn around.
Okay. So the challenge is at times patient may have freezing gait. It's like you see the feet are stuck on the ground, and sometimes these freezing gait happens like when they try to initiate the first step, or when they try to make a turn, or going through a doorway, and it's worse when they're anxious. So there's some of the strategy, such as giving them like visual cue, as the video was showing, like putting stars or putting a black lines on the ground so that they can step over it, or just by helping the patient to focus, counting 1, 2, 3, 4 as they walk, then they can overcome their anxiety and also help them to focus, because Parkinson patients cannot multitask. So by helping them to focus, counting, it always helps them. So as this complex disease advances, we'll certainly find patients not just struggling with motor symptoms, the non-motor symptoms may even outweigh the problems of the motor difficulty. So as we look at this picture, you realize the problem is not just limited in the midbrain. As the disease progresses, the degeneration can extend further to our cortex area, affecting our cognition. So patient may have some long-term memory, but their response when they try to answer your question takes a lot longer. So that's some cognitive impairment. A lot of patients may also have visual hallucination along with the cognitive impairment. And Parkinson's drug, as you notice, they all can worsen the hallucination. So we will have to be careful when we use the medication to control the motor symptom and yet not worsen the hallucination. Mood, as I mentioned, depression, anxiety is quite common, can happen very early at the disease. Pain is quite common. Aside from the stiffness, they sometimes experience like nerve pain or sometimes tingling sensations or change of the sensations of heat and cold due to the autonomic dysfunction. Smelling is being affected. That can happen very early in the disease. REM sleep behavior, quite common. Again, also can happen before they have motor symptoms. Fluctuation in the blood pressure, usually with low a significant drop of blood pressure, increasing risk for fall, constipation, overactive bladder, or erectile dysfunction. So Parkinson's Society has an excellent resource that you can look up, the non-motor symptom guide. It's nice to have a copy in your home. And in terms of management of constipation, it's important to have adequate fluid intake. And you find a lot of elderly, they really don't want to drink water or fluid because they don't feel thirst. But it's important to remind them, or at least have the bottle of water available, so they will be reminded to drink enough fluid during the day. Have fiber intake like bran, and also provide them a stool softener that's very useful. And if patients have constipation, we commonly recommend a laxative that's good for long-term use, and also been recommended by the Parkinson's treatment guideline. Senokot is useful. We always use it on a PRN basis, but for severe constipation patient, we require at least for short term every night until the constipation is relieved. Lactulose is helpful, but tend to cause a bit more gas and bloating, so it depends on how patient's doing. As I mentioned, orthostatic hypotension is common. That's important to measure the standing and sitting blood pressure. The blood pressure may drop significantly if they stand up in a lot of Parkinson patients. And the low blood pressure could be worsened by Parkinson's condition as well as the medication. So if patients are already on high blood pressure or for heart condition, it's important to have these medications reassessed. So need to lower the dose. Or if patients need to have a bit of higher sodium in their diet, you may consider having chicken broth or V8 to maintain a little bit higher sodium level so that the blood pressure won't be as low unless they have edema or heart failure problem. Compression stocking may be useful to reduce the drop of blood pressure when they're standing up. As I mentioned earlier about the REM sleep behavior, patient may have a lot of talking or kicking during the sleep. It is important to make sure there's bed rail, cushion to protect patient. And if so severe, patient may require some melatonin, which is a natural hormone to help them sleep without as much movement. Now, if patient has acute symptoms of frequent urination, it's important to check to make sure patient doesn't have bladder infection. Otherwise, see if patient has enlarged prostate, like from BPH or overactive bladder. So there are medications to treat these symptoms. Depression and anxieties are very common and often underdiagnosed. It actually cause a lot more disability than the physical symptoms. They have trouble to focus and increasing risk for fall. They are not interested in any physical activities, and exercise is just as important as medications for Parkinson management. And social stimulation is important to maintain their cognitive function. And a lot of times they may be more irritable, they're not cooperating with the self-care, poor energy, or trouble with sleep. So by providing antidepressants, they can maintain the level of serotonin or norepinephrine to allow patients to function better, especially helping with their concentration and motivation. As I mentioned earlier, the change in cognitive function is very common as patient age and also with more advanced disease. So they have trouble making plans or solving problems and affecting their safety in terms of using the gait strategy. When we say helping them to count and help them to focus, and it's important to remind them to use the walker, and often they don't remember as the cognition declines. So in fact, the chance of getting dementia with advanced disease is about 6 times higher than people without Parkinson's. So it's important to make sure the blood pressure is not too low, because they tend to respond with much slower cognitive function as the blood pressure is much lower, like less than 100 for systolic blood pressure. And medication can sometimes worsen mental function, as I mentioned, any sedative, oxybutynin for bladder, or gravel narcotics. These medications can worsen patients' mental function. Memory enhancers such as Aricept or Exelon could be prescribed to help with the mental function. And patients sometimes report seeing unusual images, such as like seeing people by the bed and or even cat, or sometimes the images could be very scary. They may be so agitated that they try to fight the image and try to hurt someone. They don't realize they're just hallucinating. So it's important to assure the patient that they're just seeing something that's not real because the brain is overactivated, perhaps from medications or the Parkinson's itself. So if the assurance is not enough, patient may require medication to reduce these images and help them to have better sleep. And it's important to reassess the Parkinson's drug. As I mentioned, they all have the risk of worsening hallucination. So we will reduce the medication based on this sequence. Number 1, stop all the anticholinergics. And for bladder, I know there's a newer one like Vesicare or Anablex. Those medications doesn't act in the central nervous system compared to oxybutynin, so a little bit better. It's important to taper off the amantadine. And then if patients on sertraline or rasagiline, this is time to stop it. Or taper off, reduce the dopamine agonist. And the last drug you want to reduce is the levodopa. As we know, this is the most useful drug to control symptoms. So if that's still not helping with this hallucination, patient will have to start on some quetiapine. The other name for that is Seroquel. Having a small dose and then slowly increase. The side effects for quetiapine is patient will be more drowsy and the blood pressure may be even lower. So it's important to monitor the blood pressure. As I mentioned earlier, make sure we avoid Haldol, risperidone, and all these medications will make Parkinson's worse. So in summary, for us to provide excellent care for the residents, it's important to have patient-centered care, communicate with the patient's family, find out what time the patient is getting the Parkinson's drug at home, and try our best to get it on time and detect any wearing off and report to the physician. And also use some of these strategies to help patients with freezing gaits when they're trying to make a turn or going through a doorway. And it's useful or important to recognize and treat the non-motor symptoms early. Thanks for participating in this webinar. Any questions?
Okay, everyone. So I do thank you for participating, and Greta, I thank you for being here to share with us today. I know we've sat through a session together a couple of times, and each time I do learn something more depth, certainly, about the role of medications in Parkinson's than I can provide. So I thank you for that. A couple of things that I took is the notion that it's not just about medication timing, which is certainly a focus that we have, but also the notion of when changing medications or when someone is arriving in care, the idea of titrating or properly tapering those medications to avoid sudden withdrawal effects. I think that's an important thing that you underscored, and I appreciate that. And the notion that I always send is one that when medication works, that a patient is more independent, and thus care is easier for all parties involved. And then I appreciate the graphic you share as well on the narrowness of the therapeutic window, realizing that as Parkinson's advances, a person's response to medication isn't as long as it once was, and thus the sensitivity to the use of that medication becomes heightened. So for me, I thank you for those specific points, but for the presentation in general. For the rest of our delegates, that is the end of the session. If you have questions...
It's Heather. I just had a couple questions for Greta because I've really enjoyed this. Boy, you've taken my understanding about Parkinson's medications to a whole new level.
Oh,
and I
thank
just
you.
had a couple of questions. In terms of looking at how medications are working, you know, in long-term care we do that quarterly, or we have some kind of a look at it. Is that too long to wait? Like, how soon should a home be reacting when they're detecting things like wearing off and maybe some drug interactions?
I think in terms of wearing off, yes, it is a progressive disease, but it's, I would say every 3 months, every 6 months, that's reasonable time because they tend to be very sensitive to medication. So it's really hard to kind of change the drug just based on a very short period of observation. And sometimes it's a bit of a trade-off, increasing the drug versus increasing the risk of hallucination. So yes, so it's important to identify when the time period, is it morning or evening, they have more wearing off. Then if that's the case for a period of time and affecting their function, then it's worthwhile to look into perhaps like increasing a little bit of levodopa during that time, or having the entacapone to help the patient. But it's always balanced off with the increasing risk of hallucination. So for someone who has cognitive impairment with dementia, sometimes we don't want to increase very much of the drug, and we rather work around it. So it's important to get the medication on time and then have the patient being on and then get them participate in the self-care. So I think having that understanding how the body fluctuates is important. And I also want to highlight the importance of a team, because in hospital or nursing home, we all work with the dietitian, the physiotherapist, occupational therapist, because Parkinson is so complex and medication is important as well as a lot of physical therapy. So if they're moving better when they're on, get them to do some exercise, like more stretches the better, because when they're so stiff, they're so slow.
Okay, so that leads us to our next session. We're planning one session in January with a physiotherapist to focus on exercise and getting people moving.
Yes.
So this is actually perfect lead into our next session. And just one more question about, can all pharmacists deal with this? Is that like part of your basic education, or are people tend to be more specialized like you are with Parkinson's? Or
Parkinson is a very complex condition, and as John mentioned, like the more you relate or more interaction with Parkinson patients and deal with their specific problems, it builds on your specialty. So most pharmacists, I would say especially the one who does consultation for long-term care, because they're more specialized in management for medication in elderly, they would have a little more training. But in terms of resources, I recently published an article that summarized the key important points in Pharmacy Practice Journal. So that goes to all pharmacists. So I hope that will kind of share some of what I learned from my past experience.
So could maybe you share that link with John, and we could send that out as part of the link as part of the follow-up package, so that the long-term care homes that are on could share that with their pharmacists, just so this information gets more widely spread.
Sure, yeah. It was just published in the fall of this year, so very timely.
and we'll be sure to include it. And on the note of specialty, of course, we make the same distinction with doctors as well, and that's why we hope that facilities will try to, if not maintain themselves, then have the family maintain connection with someone's movement disorder specialist when they arrive, just so that they are able to continue the management of someone they've become familiar with a condition they've become familiar with.
So it's better to stay with a pharmacist who knows you.
And a practicing physician as well.
Okay.
Melanie, your question, thank you for asking, and it's in the chat box regarding specific assistance in the Waterloo-Wellington area. I'm going to ask you, if you don't mind, to send me a follow-up email. You'd have received a registration confirmation from me, and I can connect you with our Southwestern Ontario office, who will be able to answer that question very specifically. Beyond that, if there are no further follow-up questions, I do believe we're finished. So I want to thank Heather again for bringing the RNAO into this. We as the Parkinson Society are so eager to share the message about Parkinson education generally, and certainly about medications and their use in long-term care. So thank you for your partnership and for allowing us the avenue to talk about this. To everyone who's attended, thank you. To Greta, thank you for sharing your expertise.
My pleasure.
And to the rest of the attendees, hopefully you'll join us for our next session in January. So do stay tuned for that follow-up.